position you're training for is much like the center on the football field. It all starts with you, and it can go bad right from the beginning if you don't do it right. We really rely on you, and the surgical care of a patient really depends on the team approach and how well you work together. Anybody can screw it up. Hopefully it's not you. Hopefully it's not the surgeon. So with that being said, I want to encourage you to really concentrate on doing the best you can and doing the best you can for your patients. Some of you, this is going to be your life's work. Some of you, this is going to be a stepping stone to something different. You may end up going into sales. There are a lot of surgical techs that go into sales. There are a lot of them that go on and become PAs, or some of them go on and become doctors or nurses. It's a great field, and I really rely on my surgical assistants, my surgical techs. They do a great job. And having one there that knows how to do things and is prepared makes all the difference in the world. Sabrina's right, though, that if you've got somebody who doesn't know what they're doing and they're trying to help, it's a disaster. And I learned it from a doctor in medical school. When I tried to help, he said, resist the urge to help, because you can try to be helpful doing somebody else's job when you're not doing your job. So that's why I say things like that. Concentrate on your job. Your job's going to be to make sure you're prepared, make sure the sterile technique, the back table's in order, everything's ready to go. Like I said, you're the center calling out the coverage for the line, and you're starting the process. I have Nick and Glenn here to help me show you how to do a total knee. I don't know if any of you have seen them or done them yet. You will at some point in your career. And one thing about total knees, it is really instrumentation dependent. It is really dependent on how well you take care of the instruments and how well you apply the instruments. If you do it correctly, it's almost automatic. I can be cementing a total knee in place in 18 to 20 minutes. It doesn't take me that long if I have good instruments and everything's ready. If something comes up and, well, let's say something's missing from the tray, it may take a while to find it, or get a replacement, get another tray. It can mess things up. And for every minute the patient's in the operating room, they're getting charged for it. For every 15 minutes longer than average, their infection risk increases. Whether or not you're doing anything on your end, but just every 15 minutes, the increase in the infection rate goes up about 9%. So if it's a normal 1% infection rate, and you take an extra hour, you've just increased that infection rate up about 1.4 to 1.5%. So that's just statistics. You guys have a lot to do with how things flow. And I was going to hopefully have two bones here, so that way I could have Nick assist with one, and then Sabrina could assist with one, and you'd see the difference. Nick's a great representative for his company and does a great job. He knows the system, but he's terrible. Sorry.
The last time we did cadavers together, he actually made me stop after about 2 minutes and go stand in the corner. I'm not lying. Okay.
I was afraid of getting stabbed. Yeah. So, any questions so far?
Where do you practice at?
Salem, Oregon. Been there for 26 years, trained here at OHSU, so I know it well.
For the hospital? Or?
Oregon Health Sciences University, got over to Emmanuel, Good Samaritan, St. Vincent's, we trained all over. And some of you may see my daughter, if you get to train in the Portland area. She is also a surgeon in training now, but she wants to be a pediatric surgeon. Because what I do is gross. Okay, so other questions? Okay, if not, then I'll kind of go through the process of a total knee. How many of you have been in surgery and have seen total knee replacements? A lot of you, okay. Starts out before the patient comes in the room. The scrub tech goes in, opens all the trays, makes sure everything's clean, sterile, clean, prepared, nothing missing. Starts to set up the table. And how you set up your table is very important. It doesn't have to be exactly the same. You don't have to do it the same as you, or you. It can do a little bit different, but you need to know what you're going to be doing and in what order. So regardless of whether it's a Zimmer, Stryker, Biomet, which is going to be a Zimmer real soon, or whatever company is being used, they're going to have trays for you to open up and put out things that you're going to need. You as a scrub tech can make things go really well by knowing what's going to be used, because you come up here and you look at these trays and you go, there's a lot of stuff in these trays, and these are trimmed down compared to what they used to be back even 5 or 10 years ago. There used to be a lot more of everything in the trays. It's really important for you to get out the things you know you're going to be using and have them in order, so you can just kind of, here's this, here's this, here's this. Because again, if you take it and go like, okay, I've made an incision, what do I do now? Oh, give me that. If you take your time, you may get confused, get lost, and again, money and infection both go up real high the longer you stay in the operating room. So, scrub techs are preparing everything, they're maintaining their sterile technique. The other thing that you'll see is infection is increased by traffic in and out of a total joint room. So if you can have everything that you think you're going to need in the room, that helps keep you from having people going in and out of the core, or sending the scrub out, or the circulator out to get more things. So you want to have everything ready. It's up to you to be prepared. And if you are, you're going to make your surgeons very happy. You're going to make your hospital happy, because they'll get through a lot of cases with very little trouble. So you set things up according to how you're going to be using them, and then get ready. Okay? So, you guys want to...
So this is obviously not your typical back table setup. As a standard disclaimer, this is probably the worst setup you'll ever see as a back table. But again, the idea is you'll be able to see how me having this set up completely incorrectly is going to be slowing you down this whole time. So I'm doing that intentionally, just so you guys know. It's one part of my plan. So.
Okay. So, any questions so far? Your setup is going to be really important, and having you prepared is really the most important part of the case, because that's your job. You're handling things. You're like the center. You're starting the process. So, let's go through a real quick Sawbones total knee. We're going to use the Zimmer Persona. It's similar in instrumentation to a lot of other companies. There's some companies that will have many more steps as far as different jigs, different things to put on, different ways to check. And your surgeons are going to have some personal preference as far as which tools they like to use and what they like to check. Like I said, if you are used to your instruments, you know how to apply them appropriately, you have to do very little checking, because you know it's going to give you exactly what you want. There are some companies and some surgeons that say they want to check everything, every step, every time. And that's okay. You may have also heard about computer-guided or computer-assisted surgery, but we're not going to get into that today. So, let's just say we've got this leg here. It's open. I've already done the dissection. And Nick's going to get ready.
I'm ready.
You're ready? You're
Almost.
ready?
I think so.
Okay. You got it stabilized here. I'm going to go around the front. That's where you go. Okay. So once we identify the landmarks, after we have it opened up, we move the kneecap out of the way. You'll hear also about minimally invasive surgery. Minimally invasive surgery means I'm making a smaller incision. Sometimes it means you're actually doing less, but the reality is, in order to get this thing through the skin and in there, you have to have a big enough hole for it. Secondly, and more importantly, the alignment, the balance of a total knee is really determined how long it lasts. You can get any model of just about any brand, and if you've aligned it correctly and balanced it correctly, it will last 20 to 30 years. So, like I said, minimally invasive is a nice concept, but you got to be able to know exactly what you're doing and where you're getting yourself into. So when I do these, I like to be able to feel these little bumps on the side. They're called the epicondyles, because that's going to give me my rotational alignment. If things are out of rotation, it doesn't work quite right. You sure? You're going to put that on there? Why? No.
Right.
Is this
Says the urge.
Now I do
I'm in
need
my corner.
drill. So I'd ask for a drill. Ready? I would find the center line just in front of the PCL attachment and drill a hole into it. After you drill a hole and that back, you hand me this device, which gives me my intermedullary alignment. I've already looked at it on X-ray, and I figured out the degree I want. The degree you set this is going to determine the angle that we cut the bone here. That determines the alignment. Most of the people coming in for knee replacements are either bow-legged or knock-kneed, and it's really important to correct that antenna pointing straight ahead when you're done. So, you make a hole, pass this down, and it's not quite as important on this system, but I generally still like to do it. That I look at where this bump is and this bump, and there's a little line across here. I tap those in or not. And I drop this right in here. And you got me at +2.
Yep.
Put it in, Nick.
See that?
See if you can put it in there.
Back to my corner. Go, Glenn, go.
Okay, Glenn, you can do it.
All right, what am I putting it in, this one?
Whichever one you
Zero.
want. Zero is good.
Zero.
There you go.
My IQ and the position.
We're doing great. Don't stop.
I'm going to do it left-handed too.
That's good.
Is that deep enough?
Yeah. So we do this, pull that off. Now this is ready to cut off the end of the femur. And if I look at it and say, that's not enough, I can move this up or down. And I put the holes in. Would you like to try to do that?
No, I'm
Come on.
totally just afraid of all of it.
Give it a try. Yeah, but I'm not touching it.
This is where I cut my fingers.
Let's see if you can get it in the hole.
Guy's upside down. Guy's upside down.
You got it upside down?
Sure looks upside down.
You set that up. Again.
I don't think the blade fits, Glenn.
Side.
I swear this is not me.
Try this one. Now,
Oh, man.
put your hand in here, you'll get cut. Yes.
Whoa.
Now, you could put another pin in there, or you can hold it with your thumb.
I'll do this. I got it. We're good. Steady hands.
Yeah. Nice job. Now, there is something I like to call the haircut rule. You can always cut more off, but you can't put it back on. So, sometimes surgeons will be very cautious and make a cut and make a recut and all that. And some of that just comes with how comfortable you are with your instrumentation and the quality that's there. So pin off.
Yep.
Pin off.
Hold the paint one.
Pins out?
Pins out. Now we take the sizing guide. Sometimes guys will come in and say, I already know exactly what size I want, and they will have templated it on an X-ray, but the problem with X-rays is sometimes there's a little magnification. Some of the systems now also have a CT or MRI preoperative planning tool that you can actually get your sizes ahead of time and get custom guides that you can just pin onto the tibia and the femur and make your cuts off of them. They still need to be able to fall back to this and double check. Because again, the issue is going to be sizing and balance of the joint afterwards.
What did you say this was called?
This is a sizing guide.
What else they use?
CAT scan or MRI guided or assisted guide,
Yeah.
what do you want to call it?
So the concept behind that is that you can basically do the surgery but eliminate all these steps that we're going through with all these instruments. So instead of having 5 trays of instruments, using that technology, you can have 1 tray of instruments. That's it, just the basics. You already know your sizes, you know everything based off MRI. So it gets rid of a big expense, just having to process trays and everything.
So one whole tray is just sizing.
1 whole tray is pretty much his sizes. So really, like with this, he's basically got 12 options for his femurs. So when we do this for a left knee, he's got 12 femoral implants. He's got 9 tibial implants, and you've got 100 different poly combinations that go with it. So just for one case, this whole table can be covered in implants, just because of all the different variables that you can encounter.
I think that's the hardest part of like getting trained. It's just so much.
Yeah.
And you're just trying to understand like,
What is all of
what,
that?
yeah.
Yeah.
So you know how to organize it, so you know.
And I think it ends up becoming pretty automatic for you pretty quickly. I mean, it's like anything, it's repetition. So, you know, the first time you do one of these, you're just like, oh my God, I have no idea what I'm doing. By the 10th time you do it, you're miles ahead. It starts to click because the concepts are all the same. You're achieving the same thing in every system to do a total knee. So,
So in this weird way, could you just like grab out and do you guys use like the sizes that you want and vary everything else?
you could, but you're probably wrong with what you think it's going to be. So,
Unless you've had a little bit of experience, or you have a rep that kind of knows the territory and says, we want to try, such as some of the guides will have like, in the older system, a CD guide and an EF guide. So look at it, we get a CD guide, he's probably going to be the EF and he's going to be the GH. So you're going to be able to look at that ahead of time. The other thing, when you have a guide, you want to make sure that it's set in the right direction and has the right orientation, because this way's left, but I can do this, and now it's right. If you hand it to me like this and I put it on there, it doesn't work. So you have to make sure that it's for the correct side that you're doing.
and there's lots of little things like that in all these systems. So it really is so many small nuances that you have to double check yourself, whether it's we get to it with the broach size, or the left and right, or on the original step, the mechanical axis. All these things you are kind of in control of, and when you hand it to them, they expect that it is how they want it to be. So if it's not, they usually yell at me, but they're really kind of yelling at you through me, which is messed up because they're crazy.
So I've got my sizing guide on here, and there are little lines on it, and it tells me what I want to know, and it also gives me different options as far as rotation of the component. And rotation is important for a couple of reasons. First of all, color tracking, how it runs, and secondly, how it relates to the femur. So rotation is important. That's where a lot of surgeons that don't do very many of them, or a lot of younger surgeons, will not necessarily pay attention to that. They'll kind of just put it on there and, oh, it looks okay. But you really need to be able to pay attention to where it is with regard to the epicondylar axis. Some people use what's called the color line. The epicondylar axis is a bone that's pretty consistent, so I always like to use that.
So what do
What
you
was
call
our
that?
size?
Oh, you would have to ask that.
I think it's an 8, maybe a 9.
Just double check.
This is my guessing.
I
Seven.
initially-
6.
Right?
All right.
So, that's my guess, and, oops,
Yeah. Sorry, we don't guess.
all right. And
So glad one more sharp thing. No.
That's everything.
So in real bone too, these things obviously work a lot better. You know, it's very flimsy with this sawdust bone.
Yeah, something like that. No,
I'm not doing this part.
you're not.
Process, let's see my cuts. Shocking, I'm not in the hospital right now.
Okay. So, we want this to cut. There's one. Then we would have retractors in here to protect the ligaments, because you really don't want to go you don't want to cut them off. There's one. Finish that. Free. Hey, there goes a piece. Hello. Thank you, Freeman. That was fun.
So really, I mean, so he's shaping the bone to fit the implants, right? So of those 12 implants, he's now making precision cuts that are going to fit that implant perfectly. So,
Hey, there we go. Now at that point, it's all ready, and you have for me
a 7.
not one of those.
Yeah, but I'm not ready to hand it.
Yeah.
Let this be a lesson.
As you can tell, it's always prepared. Thank you. Now we put this on here and count it in place, make sure that it fits.
Can you say the names of everything like doing?
Sure. So this is a femoral trowel. So in orthopedics, you're going to have a trowel for everything before you actually open the real implant, right? So he's going to put in a fake knee right now in terms of provisionals, go through a range of motion, make sure he likes everything, and then we're going to open the real implants and put the real
Give me the
implants.
7 or the 8.
That looks like a 7. Is it an 8?
No, I'm saying, can you give me the 8?
Sure.
It says 7, but you give me 10.
You know,
You may.
it could.
That would explain it.
Sure doesn't seem that much.
Yeah, that's better.
So always give them the right thing too, just in case.
You guys are getting great education here.
We're gonna be a YouTube sensation.
Yes.
I can feel it.
So, it fits on there very nicely. After I'm done with that, then take that off. Now, there are two different basic models of knee replacements. One's called cruciate retaining, which is what this model is. Then there's cruciate sacrificing, which is what this model is. And this one, see this big bar and the box in the middle? That's cruciate sacrificing, because you're going to have this big plastic knob that sticks up into that hole to give the stability that you need. The cruciate retaining retains the posterior cruciate ligament. Surgeons, about 75–80% probably do the cruciate sacrificing, this one, and 25–30% of us probably do cruciate retaining. I don't know if you had different thoughts on that.
Yeah, I mean, I think that's pretty spot on.
The reason being, when you do the cruciate substituting or cruciate sacrificing these, you're cutting out both the cruciates, you're taking out a lot more bone, but you're also taking out the reason why they may have contractures or stiffness. So a lot of people find it more forgiving and easy to do the cruciate sacrificing. The downside is, when you have this big metal box and this big plastic post and they start moving around, they get this clunk, 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 and sometimes they will jump the post, but we don't like that. I do the cruciate retaining because I'm comfortable with it. I know how to That's another thing. It's technically more demanding to do a cruise ship retaining. It saves you bone, and it usually doesn't have as much play and noise as a cruise ship sacrifice. Longevity studies show that they're about equivalent as far as how long will one last over the other. They're about the same. The main thing is you got to make sure that it's put in correctly, balanced correctly. So, I got the site all ready to go. Put in my retractors, take out the meniscus, the ligament that I don't want, and then take the finger breaker, put it around the ankle, line it up with the tibia. Now, this again is where some people will use various guides as far as computer and things like that. Have that give your orientation. I prefer not to. God gave us eyes, and we can use them to look at things. And if you're paying attention to the landmarks and it's not too deformed, you can easily get it right. So you have, this is the two. So this is going to this is called a stylus. Some people will ask for what's commonly called an angel wing. I don't know if you have one.
Somewhere.
And what that will do is allow me to put something in the slot that shows me exactly where I'm cutting. You use this to kind of feel the bone, feel where.
They love if you do this in surgery too. If you ask for something and you're just kind of like,
Yeah, we got nudge and aware. Hey, there you go. This is it. This little piece of metal has a little curve on it. And you put that in the slot, and if your tissue is stripped away enough that you can see, then you'll know exactly where you're cutting it. You'll be able to see around the edge, put it in the slot. Okay. So, up. Turn this back around this way. And your surgeon will definitely want to know whether, they'll let you know whether they want the 2 millimeter, 1 millimeter, or the 10 millimeter side.
so explain that piece. So in terms of your tibial
Why not?
resection,
When I'm cutting off the tibia, generally there's going to be a deformity of the tibia from the arthritis. Generally it's a medial arthritis, so they're kind of bow-legged. So you don't want to cut off a lot of bone from the medial side, you want to cut more off from the lateral side. Some people will say, I want to leave as much bone as possible, so I'm just going to cut it off even. You do that, you're leaving the deformity. So you have to correct the deformity in your cuts. If you're correcting the deformity in your cuts, you may have then some imbalance in your ligaments that you have to address later, but you got to get it aligned correctly. So, because I don't have the,
I'm going to hold that.
no, I was going to have to put the pins in. I trust you enough to put the pin in. I'll even hold it up like this for you.
This guy.
I'll put it in this.
That's how it works, really.
He doesn't start from the back. So it is stop. Please pull that. There you go. There you go. Got it. There.
Take over, Glenn.
Glenn's got
It's terrible.
experience. Heck, on the other hand.
Just there for comic relief.
This whole,
Yeah, other people's fun a little bit.
You're doing great, Glenn. Real good.
And this is going to determine your tibial resection, so. Yeah.
no.
All right. Then before you cut it, you want to take this thing out because it's in the hole.
You want your drop rod?
Okay, that'd be fine. There are checking devices, and you can put this on and kind of go, is it pointing the right direction? And some guys go, Okay, yeah, it is. You're checking the rotation and alignment of various valve guides. So there are different checking devices. You have drop rods. Some people also have gap checking devices that are either solid or dynamic motors. You can put like a spring in and you push on it to see how much difference there is, and that's what we do. We do balancing. I use fingers because God gave it to me and I can feel it when I know what I'm feeling. So,
So on this cut, Z, if your alignment's off and you make this cut, then what are kind of the consequences of that?
malalignment can lead to significant wear. It's melting plastic. Sure. Yeah, if your tibial cuts off, any of your cuts are off, it's going to be a problem with balance of the soft tissue. Like I said, rotation has a lot to do with the thermal tracking, has a lot to do with how your leg works. Those can lead to pain, they can lead to early wear, and if you don't get the cuts correct, like I said, they'll still be deformed. And if it's deformed, the forces are going to wear the prosthesis out faster.
Any questions so far? Like what is going on? Or?
They're all going,
You guys demonstrating exact number of things?
Hoping they never have to have the surgery.
Which times?
I'm sorry?
Are you guys demonstrating exact number of things?
Yeah, actually. And again, every system will be a little bit different.
Like sometimes it's 4 or 2 or 3, like that.
Yeah, and what ends up happening too is it becomes a surgeon preference. So, 3 or 4 of his partners, they do the exact same knee, but do it a bigger size. But do it just a little bit differently, so then you're learning the surgeon preferences. And that's something you're going to know, you just have to learn it.
You just did something with an instrument on top of that.
yeah.
What were you doing?
So, well, actually at this point, what I usually do before I give that chunk of bone to the scrub, and he goes back and he looks at it and goes, one more.
Really?
Yeah. So they can take this and kind of go, okay, that's the size of the bone, and then match it up and know about what size it's going to be using. While he's doing that, I would be cleaning off the condyles and doing my balancing of the soft tissues, because again, how well it functions is going to be determined by the combination of the position of the components and the balance of the soft tissues.
So what is it called? Any attachment?
This would be a plate handle, and this particular plate would be a trial or a size G. Now, the old system that they had, correct? The old system they had, trivial base plates were numbers. Now they're letters, and every company is going to be a little bit different as far as numbers, letters, right, and rights and left. This also is an asymmetric base plate. Asymmetric base plate is made asymmetric because when you look at the knee, I'll pass this around, it's a little bit different on one side compared to the other. And you get better coverage with an asymmetric base plate so you get it lined up correctly. You want to line up the base plate again with attention to rotation. Because if it's not rotated correctly as you flex and bend the knee, it changes the position of the components and the position of the contact. So if I really internally rotate it, then that externally rotates the leg to walk, and they walk with their foot out. But more importantly, their kneecap would dislocate. if I internally rotate it too much, or externally rotate the component, it internally rotates the leg, and they walk with their foot in and look funny. So what I will usually do is I hold this where I think I want it, then I have my assistant put in the screws. Go for it, Glenn. Here, yeah.
So on the femoral side, he was shaping the outside of the femur, right? We were cutting the cortical bone, and we made basically this kind of trapezoidal shape. On the tibia, we're going to shape the inside of the femur. So we're going to end up cementing an implant inside the cortical bone into kind of that cancellous mantle. So
And again, you can look at your tracking device and say, it's pointing in the same direction, it's in front. And that's a good way to check your rotation. But again, I don't use these very often. Now, normally what I would do at this point is put the trials on, check it. If I'm happy with everything, then I do the patella, which involves either a reamer or a clamp that holds the patella, and you cut the patella. Still, about 10% of people around the country are not doing the patella. They're leaving it. They're just kind of shaving off the bone spurs and saying they're okay. That works for probably 75 to 80% of those people are very happy with that. A certain number of those need to come back and have the patella replaced, so I automatically replace the patella, and most of my partners do too.
So the patella, he ends up cutting the patella, right? So you're left with this little disc. And then you have various sizes for your patella, which equate with various thicknesses, so both diameter and thickness. So then once he says what kind of patella he wants, what size, we hand him this, he drills 3 holes in it, and then he puts in a trial patella. So the patella's pretty basic. So we're skipping that step because there is no patella here either.
So after I've determined that everything's okay, I like all the trials, I'll then drill my holes, which involve drilling the tibia. Hey, that was fun. And then also,
Oh, we have to mallet that so we can.
so I can pretend like it.
That's right here. So this is a approach impactor. Yeah, so this is based on the tibia he sized. We're now shaping the cancellous bone to fit the actual implant, which will end up looking something like this. So he is prepping for this right here, this keel. Yeah. Are we gonna actually?
Yeah, I can drill those two. Stick it in.
We have a G and we have a.
And it's scary when the bone's this soft.
You see,
Thanks.
very loose.
Yeah, you can, it's not, because I can't put balancing on this because of the. Anyway, and put these in, check them out, and what you'll notice on this particular one, this ligament's really tight. Now, when I do these in real life, I'm stripping this down far enough so that I can get it balanced. And if I cut this off here now, it will just flop open and you won't be able to deal with it.
So on this piece in the middle, right, which is gonna basically fill the void, if you will, you've got between 9 and 20 millimeters. So and then balancing it, when he strips things down, and he's trying to, he ends up opening up the knee a little bit. He has varying thicknesses that he can put in to try and fill that and balance the knee properly. The real one, the right one.
All right, thanks. It's nice. Right. I like that. Yeah. Okay. So check it, and once we've got everything ready to go, take these off, wash everything down with a pulse lavage. Some people are using an air gun that blows CO2 to knock the fat and the cells out of the bone, because you want the cement to get into the cancellous bone. When you're mixing the cement, you get the nice aroma of the methylmethacrylate. It's a wonderful aroma, we love it. If you heat it up, it goes faster, and generally with total knees, you don't want to heat it up. Although if you heat up the implants and then put them on, it goes a little bit faster. If you don't use heated implants, it takes 2 or 3 minutes longer for the cement to set up. When I'm doing hip replacements, I heat the cement and I heat the implants, and I can usually be done in 8 minutes, whereas if you don't heat anything, it takes 13 to 15 minutes for the cement to harden. You can, but only with surgeons that are comfortable and confident with it. Yeah, if you do it to somebody that doesn't know what they're doing, you're mixing 2 or 3 batches of cement.
So you're cementing your tibia, and you're cementing your femur, and then you're going to cement your patella. Then your poly is going to snap into your tibial base plate. So there's a locking mechanism, where these two go together, and it locks right in. So 3 components are being cemented in.
Okay. So, questions so far?
Yeah, so when you're checking, you're lifting the leg up and down. Do you really do that with the patient's leg
Yeah.
in surgery?
Yeah.
So, I don't know if this is kind of a weird question, or, like, how are you, because the patient's leg is, I mean, I'm sure it's prepped, but it's not technically sterile, right?
Oh,
Or
it is.
It is.
Oh, is it covered?
Everything, yeah.
Yeah. Some people will
So you're not touching the skin?
put a stockinette over the foot.
Right.
Oh,
They-
okay, I see.
Yeah.
And then you still touch the skin, but you can touch the skin. Right.
Right.
Yeah, 'cause you
Once you've
have to.
prepped it, scrubbed it, it's fine. With most total joints, they're going to use an ioband and plastic things, so I never touch the skin until I'm closing. But it's always been prepped.
Oh.
Yeah.
That's one of those gray areas from what you guys have learned, that you can't sterilize the skin, but once you prep it, it becomes part of your sterile field, and you treat it as part of your sterile field.
Right. Okay. Other questions? Well,
Why do you use the different saw blades? Like,
okay.
what do you-
Every surgeon's going to have their preference. Some of them, it's very important to them or adamant that they get this particular one. There are different thicknesses, there's different widths, different lengths. And some of them have to be long enough. The one we have is long enough to get in, well, here. But, like I said, a lot of it's just surgeon preference. You're going to have the oscillating blades, you can have reciprocating blades, you can have end cutting blades. And when you're cutting for a post-nutrition sacrifice, you have to make a cut down here, so you need a reciprocating saw most of the time. Or you have to use a narrow blade and cut down this way and then cut across.
So is it generally if it's vertically, you use reciprocating?
You're-
That's
yeah.
what I'm trying to figure out.
Yeah. And when you do hip replacements or hip fractures, we usually use a reciprocating saw to cut up along the neck. Some people will use the oscillating saw, but it's a little bit harder and more dangerous. Okay. Other questions?
So was all the balancing done in the cut, or is it in the insert?
No, the cut is to get you the anatomic alignment. That's what I'm saying about the instrumentation. If you've got good instrumentation, you know how to do it, that's going to get you your anatomy.
Right.
Where the anatomy is going to be perfectly aligned. I do a preoperative x-ray and I figure out the intramedullary angle for the hip, and then on the leg, I look at it and I see where the ankle is and where the joint is, and I line that up. So I know that when I'm done with my cuts, if there were no ligaments, or if ligaments were perfectly elastic, it would fit perfectly and have perfect balance. But the reality is, when people have had arthritis, they get contractures, they get bone spurs in the posterior cruciate ligament that makes it tight. If they're not being the outer side is so tight that you can't straighten it out. You have to actually go over and start cutting structures as far as either lengthening them by little or just cutting them completely.
Right.
So the balancing is in the soft tissues, and that's what's going to make sure that it works right.
But that balancing's in the various thicknesses.
balancing is-
insert from one side to the other.
It's going to be done based upon the feel and how things, what we call track or roll back. As you look at how the knee works, I don't know if this will work with this one. It might. When you look at how the knee works, a lot of people think of it as just a simple hinge. It's not. It actually rotates at the same time, and the contact point for where the weight's going through, as you start to flex your knee, it actually goes back some to the different point of contact. And if you don't have the correct feel of the rollback, and if it's a hinge movement, it's not so good. You might have seen advertisements about the get-around knee. Not to disparage anybody's company here, but they're marketing it to a commonsensical thing that says, round is better. Make it round so it goes around smooth. The reality is God made us a cam in the knee that is longer when it's bent than when it's straight. So if you make it round, you have to do something on the other side that makes up for it. So when people think, it's all the same from extension to flexion, it's not. It's a different distance, it's a different tightness of the ligaments, different ligaments and muscles are tightening at different times. So that's where some craft and experience comes in and being able to balance things. Not that you guys are going to be doing that, but you're going to see surgeons kind of frustrated or asking for a balancing tool that they put in and try to figure it out. Like I said, I use my fingers and I know when to cut, where to cut, so it doesn't take you very long. But balancing is really a critical part of the success of a knee. Sizing, orientation, balancing. Put one in that's too big, like this, then all of a sudden they can't bend their knee because it's too tight when they flex it, but when they extend it, it's just right. So, other questions?
So Nathan, have you started doing total joints yet?
I did a couple, I had the opportunity to do Valverde a couple with Dr. Fisher's feet.
Yeah.
And I probably won't be back, right?
I know. I think you did fine, I just didn't want to call you out on the carpet.
No.
But, I mean, walking into it, was that kind of overwhelming?
Oh, yeah.
Sort of like, what the hell's happening?
Oh, yeah, absolutely.
Yeah. But you can see how after doing it a few times, things start
Oh,
to
yeah.
click, registers,
And I-
becomes a repetitious
And I have a
thing.
mechanical background too, just, you know, when there's a lot going on,
Yeah.
besides just the tools and the anatomy, it's just everything, you know, the whole scene.
Yeah.
Okay. You didn't do too bad, really. You were fine. As long as you don't spit in the wound or throw up on my field, I'm okay.
Hasn't happened.
They're wearing a helmet anyhow.
Yeah, they're wearing a helmet, so usually it's okay. Yeah. All right.
Do you guys have any other general orthopedic questions? Just in general, other than just about a total knee?
Do you guys have any general instrument sets? Any general ortho sets that have all the?
We didn't bring any in, and I think that's the one thing that you guys need to be really aware of going into these rooms is that your basic retractors, your Holmans, your Army Navies, kind of the general orthopedic instruments are something that I think it's sort of expected of you to know. You know, when it gets to vendor-specific stuff, there's no way you're going to know that coming into it. But your general everyday type retractors, Cobras, those sorts of things, it's very key to know that. And different hospitals will call them different things. So if you know sort of the technical term for them, and you're in the ballpark, then it's not your fault that they're calling it something stupid. So.
Other questions?
So you said that the risk of infection increases by 9% per 15 minutes.
Yep.
Is it larger with larger joints?
That's not necessarily,
Okay.
but like I said, the studies for a large group of orthopedic cases showed that that's the case. So if you hang out for an extra couple hours, you're doubling the infection risk. Not to mention the risk for deep vein thrombosis, other things.
Are you kind of being specific to patient? Bigger
well,
patients?
like, no, like if you are doing a wrist surgery, is it going to have less chance of infection than if you do a hip? Because a hip is the biggest joint, you have more open skin, does that increase your risk of infection if you have a larger area that is open?
Generally, there's going to be site-specific infection risk. In other words, the wrist has its own blood supply and unique factors. The highest risk for infections are going to be in feet, ankles, and then from there, knees, hand, foot, wrist area, elbow. Hand usually, from surgery, doesn't get a lot of infections, like facial infections aren't that common because of the blood flow and the temperature. Those are things that allow your body to fight off infections. The foot and the ankle, they're the slowest part of the body to heal. If you get a cut on your face, 3 to 5 days, it's healed up well enough, you can take out the stitches. On the foot, you're looking at 2 weeks. Ankle breaks in a diabetic, you're looking at 3 to 6 months. If you break your ankle, it'll be a month and a half, 2 months. So comorbidities like obesity, diabetes, metabolic disease all play a part. If there's inflammatory disease, that also is a problem. People that have specific kinds of disease like rheumatoid arthritis have a higher risk for infection because they're on immunosuppressants. Other questions?
How would you compare the dust and pieces flying, of like a real bone compared to this?
Wow.
Is it
Not like it, except it's wet.
pretty similar? It's not
Except it's
wet.
wet.
It's
One of the
solid.
reasons they're wearing hoods when they're in there, because they're basically in the spacesuit. You know?
Okay,
And there's a lot of spray.
Yeah.
yeah.
But they're also irrigating,
can
so
suction.
they're spraying a lot of fluids in as well that are kind of coming back, so it's not necessarily all just like shooting out of the joint.
I'm imagining dust just going everywhere.
Yeah, they have a hood, because you know where you put
Just wet.
on this clip, and then a helmet, and the helmet attaches to the clip. That controls the airflow for your hood. And you could put on your hood over it.
You
And it
actually
has a
rough.
plastic shield over it too, so if it splashes blood, you can peel that off. But then you put on your gown after that.
Yeah.
And so it's just like a,
It's got a fan that blows in your ear the whole time, so you
you can turn that down
can't
so
hear
you
as
can
well.
You can turn it down so you can hear better too though.
You can imagine what it was like.
Yeah.
You don't have to wear a mask
Yeah.
either.
Some people wear a mask because they do things with their mouth that, you know, you can see when they're operating kind of cold. Okay. Other questions?
I have a more specific question, so I'm thinking I should wait till later to ask, and we can ask questions.
No, ask it now.
Ask the last.
Ask one.
So out of this, like, what would you bury? What would you pull out initially when you're setting up your back table, and what would you bury?
So, I would say trials stay up because no one knows for sure, right? A lot of guys will do the patella either first or last. Dr. Zurski will do the patella last. So that can stay buried until we get close to the end. I mean, again, like he was saying, he's usually cementing after about 18 to 22 minutes. He's in that range. So he's on autopilot, and his text now, I mean, Nathan can attest to this. It's kind of like,
So fast.
I don't know what just happened. People are throwing stuff everywhere. So for him, Albert, Dr. Zurski's tech, and Nathan then, they took out pretty much everything they thought he would need. They took out a decent range of sizes that they're usually always right. I don't know how, but they are. So he kind of just puts everything to the side. But I would say, as the new tech for most surgeons, I would have access to your different trials or sizes, because those are where you're going to have the most change. You're going to take out your general instruments, and then you're going to have 1 or 2 trays of trials that you want to get your hands on. So, and again, it's kind of every second they're waiting, it's awkward. Just this awkward silence of waiting for you to find it and get it.
Yeah, that's why I'm wondering exactly like what you would put like first, second, last, how high would would stack it up like exactly how you would bury it. So.
Yeah, and that just kind of depends on the tax preference.
And as Nick mentioned earlier, early on, this is all repetitious, so it'll come to you. Eventually, you'll get it.
You'll see
And
the
it's-
Yeah.
first.
And it will be, if Dr. Zisky doesn't have his normal tech with him and it's someone else coming in, they'll do it a little bit differently. And it might be, they'll ask me, what does he do? What's he doing first? What do we need to have set out? Et cetera, et cetera, et cetera. So you're fine. There's always someone there who's going to be able to help you through
Or
it.
you can ask.
Or you can
Say,
ask.
"How do you like this? What do I need?"
You use it to tell the first or second.
Sure, absolutely.
In some hospitals, we had a crazy scrub tech that should actually be a doctor because he wrote everything down and he has it written down exactly in the order, the way I do it, the way every other surgeon that he ever worked with. He had it down so that he knew exactly what he's going to have. But other people will come in and say, "I'm here. What do you want me to do?" Open up the trays, set them up, let me pull out, and that's something that I'll do on the weekends when I'm going in to do like a hemiarthroplasty with someone who normally scrubs urology case, and I'll say, "Okay, open everything up," and I'll go this, put them out on the table,
That's awesome.
and then we go from there. So if you don't know what you're doing, ask, and some will look at you and say, "Have you read the protocol?" And that's the other thing that you have a big advantage is that you all can read, and you all have access to computers, and every manufacturer has a protocol for what is supposed to happen. If you look at the Persona protocol, I don't know if it's 12 steps or however many steps it is.
Yeah, I mean, there's
There's a whole bunch of steps that you can look at just so you know the direction you're going. Once you've done a few of these, like I said, regardless of the manufacturer, you get the idea of these are the things that we're doing.
And Nick did have brochures for you to keep, and he will, I will have
Okay.
access of those soon, very soon, and I will pass them out to whomever is interested. So, well, especially my class right now, so.
And it's kind of one of those things too, if you go, like Dr. Zerski said, if you go online and you Google, say, Zimmer Persona surgical technique, or Stryker triathlon surgical technique, or any of these major manufactured products, you'll go to probably a 40 or 50 page online booklet that goes through step by step by step by step. And so that's a good baseline for any sort of case, is to know it that way. And then, again, surgeons will have their own unique way of doing things. They might skip 10 of those 40 steps or whatever it is. So, but you do have access to a lot of other information online.
And as I mentioned to my class, take notes, 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 and I showed them where I start off each and every step, and it was a page, this, and then I downsized half a page, and I turned it over, and then it got smaller, and then pretty soon I had like a business card size. My surgeon's preference cards, their pet peeves, their idiosyncrasies, all these things. But then eventually, it just you're with them for years at times, and you just automatically know. It's just
Are you taking those while you're in the OR?
before the cases, and if I have a piece of paper, yes, and I generally do. Sometimes because you're supplied with a sterile pen to begin with, so I'll even write it down on my back table on the cover, the table cover. So yeah.
You can wait a surgeon, but idiosyncrasies with business card.
Mine said it, wasn't me.
So what does your team look like now, like on a total, if you're gonna do a total knee, is it?
On a
is it
total
you and
knee
then
or a
just
total
your
hip,
assistant?
I'm still asking for a second scrub or a second assist because the scrub's gonna be handling all this. Then I want another person basically to hold retractors and help with the leg. I have a PA also. There are some people that will use a holding device, and that kind of substitutes for that. But that, I don't like that holding device, and it slows me down. On a hip, I like to have two people, I do posterior approach, and I like to have two people opposite me, one to hold the leg and one to hold retractors, because when you're doing the acetabulum, you need that to get down there. Once the acetabulum's done, I usually have one person come around. But the scrub person is usually just doing scrubbing and not holding. If I'm doing a hemiarthroplasty for a fracture, I'll just have one person with me because I'm not doing an ask have you.
So you do it to the total. So you do it to the total.
Three helpers when I'm doing a total.
That's amazing. And you do it in 20 minutes?
Well, we're done in 40 to 45 usually is when we're actually out of work. Yeah. But like I said, we're cementing usually about 20 to 25.
It's still really good. I think we did that in 28, and there was the surgeon and his 3 assistants, and then it was me as a scrub tech and the second.
So they must have slowed it down. Yeah. So, if you want, come up and look at things. There is no substitute for handling it, as far as you can go online and look at it, you can go on, you can read the books and stuff like that, but it's kind of like, I'm going to give you the driver's manual and the owner's manual to your car, and you're going to read it, and then all of a sudden I expect you to go out and drive it. You need to have some practice with it.
And you can do that. Really do
So,
that.
come on up.
Go crazy. Nathan's gonna show you how it's done. I didn't realize that was you. I was like, it's Nathan, and I felt bad about that. Sure. Yeah. I'm handy. Yeah, I mean, it's, again, you can read how these things work and you can see how it works, but then when you actually try to go to put something together,